NTA Kaduna, your star station.
Every 12 minutes, Nigeria loses one woman to complications from pregnancy or childbirth. By the time you're done watching this video, 2 women will already have died in one corner of Nigeria or the other as a result of childbirth or complications related to childbirth. Maternal mortality rate of Nigeria, the most populous nation and the largest economy in Africa, has for long been in such an abysmal state and does not seem to be improving. A recent joint report released by the World Health Organization, United Nations Population Fund, and the United Nations Children's Fund stated that 58,000 Nigerian women died in 2015 because of child delivery or complications related to it.
Women, by their reproductive role, they have the responsibility of getting pregnant. And when they do, it becomes a responsibility of the entire state to ensure that they deliver, without any problem.
And Nigeria is losing 512,000 women yearly. 500,000 births in a year through childbirth. If you look at the number, that is about more than 200 planes crashing a day. If we have a plane crash a day and it's carrying 200 people, this country will be up and down. The whole country will be upside down. However, we can equate the same number of people dying daily as a result of childbirth. But because the death is not recorded, or it's not made loud, people don't know about it. Or people know about it, but they think they cannot do anything about it.
I had normal pregnancy through until when I was 8 months. I went for antenatal and I was asked to go for cervical examination. And there I was told that I had a borderline pelvis. The doctor explained that I had a 50-50 chance. I could either give birth myself or I would have to go through a cesarean. But then he said with very good contraction that I could give birth by myself. But the day I started labor, I went in contraction normal. I dilated fully. And then the doctor said if I feel like pushing, I should push, and then contraction ceased. Nothing again, it was silent.
Akwai wanda na sani ma mun samu mutum wajen 4 ne wanda suka mutu wajen haihuwa wanda na san su ba a zuwa awo saboda wahalar ba inda za a yi bi hanya a zuwa ko kudin moto da na mashin ma ishe ka gani ba inda za a yi mata su rika zuwa awo yanzu BCG na yara ma nan ba shi da za a rika zuwa ana musu BCG ba shi tunda kafin a ce an je ba hanya kuma yanzu ana fama da matsaloli.
Nigeria's maternal mortality statistics have been discovered to represent 15% of the total global burden, with less than 3% of the global population.
The very WHO definition of health, where it says it's a complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. And specifically, when we're talking about maternal health, we're talking about their reproductive health. And that definition also extends to talk about the fact that it's a complete state of physical, mental, and social well-being in their reproductive systems, its processes, and its functions. So, but unfortunately, the way we gauge maternal health is not from how healthy they are, but how many we lose, that they die from a result of pregnancy and pregnancy-related causes. And that's why the whole world kinds of measures how well we're doing by how many mothers we're losing as a result of pregnancy using what is called the maternal mortality ratio.
What even danger signs of pregnancy are, some of them don't know until complications start. They do not know even where to seek help. And they also do not know, again, in terms of education and public enlightenment. Because, again, in some areas, our culture, our traditions, again, also create a problem for things like this. The other one has to be the delay in accessing care. And there are many reasons for that. Perhaps, again, the facilities may not be available, even if they know what to do. They don't know where the facilities are, or the facilities are inadequate. They don't even know how to get to the facilities. If for reasons of poverty, or for reasons of lack of transportation, or where those facilities are located and that kind of thing. And even when they access care, the third one might be delay in getting the proper care, maybe in terms of accurate treatment. Could get to the facility, they may not have the medical worker who actually fully understand what they want to do. They may not necessarily have the competence, they may not even have the equipment, the right equipment, etc. So there are a whole load of challenges, especially in this part of the world.
Death is not necessarily the result. The conditions through which new Nigerians come into this world in many cases put both mother and the child who survive at very high risk of sundry health complications.
At that time, the way he dropped it, I got scared because he just dropped it. Madam might take him to the siesta. It was like a death sentence. I got scared, and at that time of the night, it was around 3 a.m. My husband had already gone home. And there was no way he could come back because where we lived to the hospital was quite a distance. And the doctor said that they had to rush him to the theater. So I had to sign a consent form myself. And then I was taken into the theater.
My experience that day wasn't a very funny one. See, I started having contraction by 11 midnight. So initially I thought the contraction wasn't that serious. So I was like, let me just relax. Maybe by 3-4 I'll start going to the hospital. But when the contraction started coming frequently, like let's say every 5 minutes, so I just felt like I need to go to the hospital. It's not something I can bear again. On getting there, that was some minutes to 1. So only for us to be horning, the security man came out. He was like, "You people should go away. Doctors are on strike. There's nobody to attend to you." So we were like, all hope is gone, because that was the hospital I registered with. I didn't register with any private hospital also. So we were just like stranded. We don't know what to do. So we started checking all the hospitals along the streets. I remember we checked one private hospital. They were like, "We have to deposit 200,000 before they can attend to me." My husband was like, wow, that he doesn't have that kind of money. So we have to leave that place. We're like every hospital on the street, we're just knocking. Some will open, some will be like, we don't bear children here, we only attend to children that we can't attend to. So just check somewhere else. Some hospital will check, they won't even come out to check who is at the gate.
What I'm not happy at, after the operation, they packed me welcome. I was there. I was hearing, because I'm not there, but somehow there. So I was hearing, woman top part is like bẹ́ẹ̀ yẹn. Ṣé kò sí anybody tó mójútó? Our family is still around, you know, something like that. I was like, I kept quiet. Like, hey, is this how I'm going to die? Nobody attended to me there. I was there till daybreak.
Our health-seeking habit is poor. 2, when we decide to seek it, are we finding it easy to access? 1, because we don't have enough. Transport becomes a problem because of long distances. Communication is also another problem. By and large, that will explain that. And then finally, when we get there, our budgetary allocation to health is usually 2-3% or something for health. And you know, for example, that particularly when you're talking about the third level, the infrastructure to put, the manpower to put there, to utilize those infrastructures. So you get failed at so many different levels. That's why sometimes we say it's commitment that is lacking, both on the side of the women themselves and also the system.
Many factors have been identified for this undesirable state of affairs in the country. These include poverty, prevalent lack of basic education, cultural and religious fixations, lack of access to skilled health workers, lack of access to necessary and required drugs, urban-rural dichotomy in resource distribution, poor quality of health services at all levels, socioeconomic status discriminations in access to medical care, lack of ambulance for obstetric care in most states of the country, and the absence of good governance.
Of course, when they get to the health facility, are they well equipped? Do they have the personnel? Do they have the skilled personnel? Do they have all the equipment, to actually address whatever the situation is? So that's one aspect of intervening.
Some of the facilities we actually visited, some of them no staff, some of them no 24-hour services, some of them you will only find just one nurse due to shortage of staff, or just a two working in that facility, and they will only work for a certain hour and then nobody again.
The universal coverage in terms of provision of services is a mandate of government. They provide facilities, and they look at spread in terms of equity across the population. They also deploy staff to the location and ensure that the 6 building blocks of the health system are embedded, which is now what is the state's policy in terms of maternal and child health issues. And they also look at that means within that profile, you have safe motherhood issues. You have a number of programs embedded within that safe motherhood issues.
Over the years, both the federal and state governments in Nigeria have paid lip service to healthcare generally with little commitment to action. In April 2001, leaders of all African Union countries, including Nigeria, gathered in Abuja, the Nigerian federal capital, and pledged to commit 15% of their annual budgets to healthcare in their respective countries to catalyze the attainment of global standards of healthcare on the continent.
I would say the health insurance bill, the maternal and child health collaborated with FANI, which we looked into the bill, studied it, made inputs, and then came up with our issues, which led us to go to the State House of Assembly. We seek audience, and we met with Chairman House Committee on Health with his committee members, made our submission. And this week, the bill was passed into law.
The health insurance is one of the tools under health financing to ensure access to affordable, quality healthcare services, which also includes, like I said before, maternal and child health services, which will help to reduce the issues of maternal morbidity or maternal mortality, which we know that for Nigeria, we're recording very high numbers. And so this is one of the ways of reducing maternal mortality and morbidity.
If this was backed by action for only 2 years since then, the change in maternal, newborn, and child health would be very huge and impactful. Health facilities would have increased in number as well as upgraded. Quality of services would have improved. Health workers would be better incentivized, and work attitude would have improved among them. Alas, almost 2 decades after, Nigeria is still struggling annually with a commitment of 5% of budgetary allocation to healthcare. The need therefore arises for all entities concerned to raise the bar of accountability with respect to their stakeholding to help in ensuring life and good health for intending mothers and newborn babies. It is imperative for Nigeria to tackle the mother and child challenges head on. But this will require more actions than words.
What are the causes? Why are women in Nigeria dying? Then we can't address it, and that's why the use of evidence becomes very important. And the project I'm working on, we are using evidence for advocacy and then to hold governments and whoever is responsible for the health of women accountable. So for example, there are some states in this country, they say they are providing free maternal, newborn and child health services. So a woman can walk into a facility, get the services free, get her drugs free from the moment she gets pregnant till she delivers. But if nobody is monitoring and ensuring that those things actually happen, then we will just mouth it. It's very good for politicians. Oh, I've provided free drugs, free this, but who is measuring that that is actually happening? I'll give you an example. One of the states we've worked, they started this free program by allocating funds on a quarterly basis. Now, the typical scenario was that the first month that they allocate the funds, women get the services free and all these things. By 1.5 months to 2 months, it's all gone. And it's not that it's all gone genuinely, if you understand what I mean, there are leakages. So we came in and showed them the evidence that, look, giving money on a quarterly basis will still not give you the optimal health that you want for these women. So why don't you change to monthly? That way you can regulate it and monitor it. And so that evidence, advocacy to the government, and they've changed, and so we can make them accountable to say, when you release that money monthly, most likely these women can get the free services and they can be well.
Some of the things we've also been doing is analyzing the budgets and tracking the budget spent in maternal and child health, especially to ensure that the budget is actually something which is tailored towards the priorities that affects mothers and children, especially.
We address the first delay: poverty, knowledge, enlightenment. A major issue is sensitization of people, educating the people, changing behavior. This comes to public enlightenment. And there are different methods. You've got flyers, you've got health talks, you've got what we call medical missions, you've got outreach services that will go into the community. And what we do again periodically, that's community storms. Yeah, we go to different local government areas for using the platform, the First Lady of Lagos State, to actually sensitize the people on the issue of maternal and child health issues. And we do that periodically. We go to local government, to the grassroots, to the community, just to educate them, give them material, tell them what and what they need to do, give them the issue of family planning, whatever it is. We discuss all those. So that's that.
This has led a section of the civil society to launch a sustained campaign of accountability to wake up all sectors of the society to their incontrovertible responsibilities towards maternal and child health.
Everybody should be concerned. We are all responsible, we are all accountable that our women survive. When we have a population where half of the population, more or less, we have 50% men, 50% women, approximately. When we have issues where women are dying in the process of giving life, then there's a problem. We need to create awareness about it. We need to ensure that everybody knows the role they need to play to save the lives of women.
Nigeria is one of the countries that are committed to free maternal health. And it's also because of the high maternal mortality, that we have recorded in the past years in Nigeria. Nigeria still remains as one of the highest countries where we have recorded maternal mortality in sub-Saharan Africa. In fact, in the whole world, we are ranking countries like India, who have the highest maternal mortality ratio, in the world. So, coming from that background, then it becomes very important for us to take the issue of maternal mortality important. And that's what led to organizations like my organization, Women Advocates, DEFCOM, and other organizations coming together to work on an accountability framework that will help us in raising the issues relating to maternal deaths and also ensuring that governments are held accountable, for the deaths of women which are preventable.
The state-led accountability mechanism, like the name says, it is state-led. So it comprises governments, civil society organizations, media, health professional bodies, traditional rulers, and significant others. And the simple concept is to bring all the key stakeholders together and say, we have a common goal. We want to improve the health of mothers and newborns and babies and children. So we come together. Our own model is that mechanism is subdivided into 3 committees. So you have the evidence, they are the ones churning out what evidence it is. And you have the advocacy subcommittee, they use the evidence to do advocacy. And then the knowledge management and communication subcommittee, which is more like the media angle communication. So they use the evidence-based advocacy to ensure that everybody knows about it.
Well, the media has a lot of role to play in terms of holding government accountable, holding communities accountable, holding men or husbands accountable, even holding women accountable. Because the main thing is we all have the responsibility to ensure that a woman who is pregnant survives. A woman who is pregnant do not die in the process of giving life.
We are not hit 100% in terms of expending money for health. So that's the concept of our state-led accountability mechanisms, bringing government and especially civil society organizations together.
Then, not again shall death claim Nigerian women in their prime. Not again shall darkness pervade families and communities at the prospect of a newborn. Not again should Nigeria represent an odium in the Committee of Nations for its lack of accountability in maternal newborn child health. Not again. Not again.
NTA Kaduna, your star station.